to this MedEClasses lecture series in which we'll be talking about growth hormone deficiency, which is one of the most common treatable condition that we encounter as pediatric endocrinologists. Unfortunately, most children who come to us with growth hormone deficiency come at a very late stage when the treatment may not be possible or may not be very effective. So what we'll try to do over the next 45 minutes or so is to try to focus about the various aspects in terms of diagnosis and management of growth hormone deficiency with particular emphasis on the guidelines which are there, as well as some practical information about how the newer forms of growth hormone may be of benefit from that perspective. And we will be trying to cover all those aspects from that regards. So why are we really concerned about growth hormone deficiency and what implications does it have in terms of our clinical practice? I'll start off with this case because diagnosis, of course, is most important. If you don't diagnose growth hormone deficiency at the right time, you will not be able to achieve the right diagnosis. So this was a 12-year-old girl who had a height of 120 centimeters and a weight of 15 kgs. Parents were of a normal height. And if you look at the chart, clearly we can see the child is below the chart, she is below the population, she is below the family. But what's more striking is that there is a predominant effect of the weight, which looks like a nutritional pattern of growth failure. However, the initial workup showed a normalish hemoglobin with a normal TSH in celiac profile. IGF-1 was low and a basal growth hormone was found to be low, based upon which the child was diagnosed as growth hormone deficiency. But if you really look at this overall patient profile, this is a scenario in which you have a predominant effect with regards to the weight. This makes endocrine cause less likely, and there is a need for consideration of a overall process. And here, growth hormone treatment did not do any benefit. When the child was referred to us, further evaluation showed us that the child actually did not have a growth hormone deficiency, had a IgA deficiency, which had a masked celiac on that regards. So clearly, before we talk about treatment, we need to really understand about how do we diagnose, assess, evaluate, and manage in that perspective. All of you can go and have a look at our website, learning.growthsociety.in, which has got a lot of resources related to pediatric endocrinology. We have got our learning portal, including YouTube, which has got over 600 videos with a large viewership across the globe. We run multiple courses which are validated with regards to pediatric endocrine learning, including fellowship courses, which are both hybrid online and offline model, as well as pediatric endocrine courses for postgraduates. We regularly run grand rounds, particular lecture series, as well as particular scenarios, lectures like these. We have got publication in the form of pediatric endocrinology protocols, basic pediatric endocrinology, and advanced pediatric endocrinology, which are available both in the hard-bound fashion as well as the Kindle version on Amazon. And we've got a mobile application which helps in terms of evaluation and management. So I'll be focusing today predominantly in terms of how do we reach to a diagnosis of growth hormone deficiency, and then what would be the best way to treat from that regards, right from the initiation to the continuation, as well as the possibility of transition into the adulthood. We'll also touch base briefly about the newer advances, particularly the long-acting form of growth hormone from that perspective. So what are the options we can use for growth promotion? We can use growth hormone, which acts largely not only through the liver to increase the growth hormone receptor producing IGF-1, which again impacts the growth plate. It also has a direct effect on the growth plate, endocrine and a paracrine effect as well. The other way, of course, is to really look at the overall impact of improving growth, is to delay the epiphyseal fusion by inhibiting the estrogen level using either a GnRH analog, which will suppress puberty in both boys and girls, or use aromatase inhibitors in boys, which will provide further growth. Another parameter which has recently been launched is a C-type natriuretic factor related peptide, which will be there. So the options are either to increase the rate of growth using growth hormone or IGF-1, or we can delay the rate of fusion by using a GnRH analog or a aromatase inhibitor. Now, growth hormone treatment is clearly the treatment of choice in growth hormone deficiency because compared to IGF-1, it gives us a better response. It does not give rise to hypoglycemia. It does not give rise to an elevation of IGF-1 to a great level. So if you have growth hormone deficiency, growth hormone is the treatment of choice. IGF-1 treatment is only indicated for a genetically proven growth hormone insensitivity, or if there is a growth hormone deficiency variant wherein giving growth hormone has caused antibodies to be formed, and that can have implications in terms of growth hormone responsiveness. So that's the only scenario where IGF-1 is actually approved in terms of use. Now, growth hormone is available across board and it's being used for around 70 years. Earlier, it was pituitary derived, but because of the prion mediated Creutzfeldt-Jakob disease, 1984, thankfully, there was the recombinant growth hormone which was available, and subsequently, it's being used across indications. So, indications are broadening, including chronic kidney disease, Turner syndrome. And then we have the long acting GH, which was the original one, which was more painful, had more swelling. And then subsequently, we had other indications opening up, including Prader-Willi syndrome, SGA, and clearly ISS. So now the overall expansion has happened in terms of treatment. I'll largely be focusing with regards to growth hormone deficiency because that's the agenda for today. And I will also be focusing predominantly in terms of the impact which is there of the guidelines which are there, how they advise us to change in terms of therapy from that regards. So, how do we decide about whom to treat, when to treat, and what dose to use? We remember that growth hormone does different roles at different ages. So, the levels are low in fetal period, they increase in childhood, reach a second increase, particularly during puberty, where we see a huge increase, they then come down, and during senescence, we have got a lower level of growth hormone which is there. The typical production rate of growth hormone in children is around 25 microgram per kg per day, which basically increases during puberty to around 35 to 45 microgram per kg per day. And this is the time when growth hormone is working. The major impact of growth hormone is during the childhood and the puberty phase, particularly during childhood. So, if you're diagnosing somebody late with growth hormone deficiency, you would have implications in terms of height outcome. Subsequent to that, it also has an impact on bone, which happens till around 25 years of age. And there the requirement will be like 25 microgram per kg per day. And finally, it has got beneficial effects on cardiovascular health and quality of life by the effect on adipocyte, where the requirement will be less. And after somatopause, typically the dose will be much less. The typical dose that will be there around anti-aging will be much lower from that regards. Growth hormone is available in the form of biological compounds which require much more evaluation and testing when we start using them in a market. These are compounds which are derived, so they are biosimilar compounds, need to have a lot of evaluation and impact there. The biosimilar compounds, however, have advantage of lower cost in terms of growth hormone therapy. So as discussed, it's used in GHD, Turner's, SGA, CKD, Prader-Willi, and ISS. I'll be focusing predominantly on growth hormone deficiency. There are other indications which are emerging from that regards. So the Pediatric Endocrine Society guidelines, as we discussed, talks about oxology as a primary criteria with the need for growth hormone stimulation test and low IGF-1 also in a similar scenario. So the major emphasis is the most important thing which decides treatment is the height, and that should be our primary motive from that perspective, and that will be really able to tell us the need. Very importantly, before we start growth hormone, we should ensure that the pituitary function is normal. There should be a normal free T4, normal cortisol, because growth hormone is going to increase the metabolism of both cortisol and thyroxine, precipitating hypothyroidism and cortisol insufficiency in that regards. Neuroimaging is absolutely essential because we do not want to miss a CNS lesion and start growth hormone, because growth hormone can be given at least 1 year after final treatment of a neoplasm like a craniopharyngioma. Very importantly, we should look at contraindications for growth hormone like Bloom's, Downs, and Fanconi syndrome, which may be present in that regards. And as discussed, we have to wait for at least 1 year after treatment of malignancy. In multiple pituitary hormone deficiency, careful dosing is essential. So acetate deficiency, we don't want to give too much hydrocortisone because that is going to suppress. So typically 6 to 8 or up to 10 milligram per meter square per day of hydrocortisone should be used. Do not use prednisolone or dexamethasone, which are growth suppressing. For TSH deficiency, thyroxine, and again try to maintain the FT4 in the high normal range. Gonadotropin deficiency treatment should be age appropriate. So around 12 year in girls, around 13, 14 years in boys would be a right time, and we can use multiple agents in terms of treatment. The dose, as I discussed, is based upon the clinical dose production. So in childhood, typically we'll be using 25 microgram per kg. Puberty, the dose may be increased, but the guidelines do not suggest a blanket increase in everybody. In adults till 25 years of age, we can use 25 microgram per kg per day. Men, the dose is around 200, and women need more dose because of the estrogen effect on the liver of 300 microgram per day. Elderly, the dose is only 100. Very importantly, in somebody who has got a severe growth hormone deficiency, start with a lower dose because giving too much dose may cause problems. And somebody with mild, we may need to start off with a higher dose. At puberty, there may be a need to increase the dose, especially if the child is short at that point of time. However, there is no routine recommendation to increase the dose in everybody around puberty. Now, studies have clearly shown that depending upon the catch up response, we can then decide about how to go about in terms of treatment. And this catch up in the initial phase is a good predictor of long term response. We should look at height, which is expected to increase by around 10 to 12 centimeters in the first year and then 8 to 10 centimeters subsequently. We expect a height SDS increase of more than 1.5 in 2 years. If it's less than zero point 0.5 in 1 year, that's a cause of concern. The Growth Hormone Research Society has clearly talked about this. If the height velocity SDS is below 0, height SDS is less than zero point 0.3 per year, and height velocity less than 2 centimeters per year, we have to worry. Look at bone age. There is some bone age advancement, but it should not be inappropriate. Also, look at IGF-1. The levels should be within +2 standard deviations. So, while we want a response, we don't want the IGF-1 to go sky high from that perspective. There have been studies which have tried to look at whether titrating the dose of growth hormone as far as IGF-1 would result in better outcome, like we do it for thyroid or we do it for other hormones. The problem here is that the dose requirement may be very, very high, and the height increase may not be huge. So the guidelines do not recommend IGF-1 based dosing. The main reason why we are doing IGF-1 is to prevent any toxicity which is happening. Lower the level of growth hormone, greater the height of the parents, higher the dose, earlier the treatment, the better is the response. Now, if we start treatment at an early age, we are not only giving lesser dose because it's weight dependent, we are also getting good response. That makes early identification of growth hormone deficiency absolutely essential. If a child is not responding, think of other conditions like celiac disease, hypothyroidism, look at nutritional. Growth hormone treatment may unmask central hypothyroidism, which we have to evaluate for. Check for adherence, the technique, and whether growth hormone antibodies have been formed in GHD 1B in that regard. So we have a 10-year-old child with short stature whose peak growth hormone is 0.1, very, very low. The child is extremely short, started with growth hormone, good initial response, but subsequently the growth velocity is less. This is a classical case of GHD1 in which you have got no exposure to growth hormone to begin with, and now once we give growth hormone, there are antibodies which are being formed, resulting in decreased response. The only possible treatment in this scenario would be to use IGF-1 as therapy. 13-year-old boy with GHD on GH, there is a good response with a reasonable dose. Now the child has entered puberty and is still short. So what can we do to improve the height from here? So in this scenario, the options could be, as I discussed, is to either delay the puberty using a GnRH analog or aromatase inhibitor to delay the epiphyseal fusion, or we increase the dose of growth hormone. So these are the three options which are available. All of these are experimental, so they should be done after detailed discussion with the family and see how much the height would be improved from that regard. So pubertal management, as I said, you can use higher dose. 50 is the recommended dose. You can go up to 50 microgram per kg per day, or use GnRH analog or aromatase inhibitor to increase the duration of growth. The guidelines clearly say that there is no routine role of increasing the dose, but it can be done on an individualized basis. The adverse effects, it's a very safe therapy. Growth hormone is one of the most safest therapy if given in the right dose, in the right individual. Some people will develop edema because of protein retention. This is a reversible phenomena. Benign intracranial hypertension occurs in 1 in 500 cases. There may be unmasking of hypothyroidism, so monitor thyroid at 3 months, 6 months, and 12 months. Very important side effect to remember is slipped capital femoral epiphysis, which is not just the effect of growth hormone, it's the effect of rapid growth. So, if a child grows rapidly, the epiphysis may slip. This will present to you with somebody who was normal, suddenly starts limping, has pain in the knee, pain in the hip. This is something important to identify. Dysglycemia absolutely uncommon in growth hormone deficiency, more common in Turner's or SGA, and tumorigenesis is an important factor. It's very safe, but we need to understand that there are some studies which needs to be evaluated. The major reason why many people talk about the effect of growth hormone on tumorigenesis is the association of high IGF-1 with tumorigenesis, especially with acromegaly. What we need to remember is that when we treat with growth hormone, we are not only increasing IGF-1, but we are also increasing the IGF binding protein. Therefore, the free IGF-1 rise is not that much, and the risk of malignancy theoretically is not there. There are large databases which have looked into these factors, and they know that there is no effect on the primary cancer. Recurrence is also not increased. The only thing which has been shown to have some increment is the development of the second tumor, which may happen slightly early. This is the large database, a European study which we looked into and was found to be a bit safe from that perspective. There is some theoretical concern about meningioma, and again, the authors suspect that there is a meningioma risk with cranial radiotherapy, and GH may not affect the risk. So, the effect that we are seeing is more about the effect of radiotherapy rather than that of growth hormone. So, this is something which we need to really remember. Now, many people ask, once our treatment is over and height is over, what do we do? Whether we need to treat them or not. The main thing to remember is that growth hormone also has the effect on bone, especially till 25 years. So the United Kingdom guidelines do talk about the treatment till 25 years. Adipocyte, you can use it for adult growth hormone deficiency, and then you can consider from that regards. If you're talking about only growth, bone age of 14 to 16 years for girls and boys is time when the height will fuse and the growth velocity is less. Bone, we can give it to 25 years, and for adipocyte, we need to do a retesting in adults and use a cutoff of 3 nanogram per ml, especially after an insulin or a arginine test. Transition should be done only if there is after a washout period of a month. No testing is required in somebody who has got a multiple pituitary hormone deficiency, imaging issue, or CNS insult. The test is insulin or glucagon with levels less than 3 in that regard. For adult GIG, the treatment is mainly for the bone health, quality of life, and cardiac risk. The diagnosis should be reconfirmed, and the dose is for young male 200, young female 300, and for older individuals it is 100 microgram per day. From that perspective, I'll just run through the guidelines from the GRS Society 2019, and they really talked about very important factors which I already highlighted too. Is that IGF-1 based dosing is something which they do not recommend. The routine recommendation for pubertal increment is not there, and they recommend that if the growth velocity of 2 to 2.5 centimeters per year is the time when you should stop growth hormone in that regards. And very importantly, for somebody who has an ongoing tumor, a gap of 12 months is what is recommended. There are prediction algorithms which can guide us in terms of growth hormone dosing. IGF-1 should be 0 SDS, not above plus 2 SDS definitely. And if somebody's height velocity is below 2 centimeters per year, that's a major cause of concern, and you have to reevaluate for other possible causes in that regards. Now, what's new? Every time somebody comes to us with growth hormone deficiency, the question of the parent and the child is, how long do I need to give the treatment? And this injection daily is difficult. So the newer options include the long-acting weekly preparations, which have been there for quite some time, but have now been developed using a newer mechanism. Inhaled growth hormone, still experimental, and the role of secretagogues like methimorelin is again experimental. So largely we're talking about long-acting growth hormone, which is weekly growth hormone, which will help with regards to achieving height without the need of daily injections. The two major ones which are available are somapacetan, which has basically been developed by increasing the binding of growth hormone to albumin. It's been used across indications, not yet approved in India. And the other one is somatogron, in which the growth hormone is bound to a HCG moiety to prolong the duration of effect. Again, This has been shown to have a similar effect as compared to the daily growth hormone, and this is now readily used in India from that perspective. So we have tried to cover the entirety of growth hormone deficiency, right from short stature evaluation to confirmation of diagnosis to evaluation and to management, with a brief overview about the various aspects of evaluation. All of you can go and have a look at our books, the protocol book, the basic and the advanced pediatric endocrinology, our application which can help assess in that regards, and our courses on our website.